80% of people will experience the baby blues.
Is mum brain a real thing?
There is no evidence that a baby ever needs to sleep on its own.
Obviously, there are big dangers about coasting, but also there are ways to do it effectively. Dr. Kavita, thank you so much for coming on.
No.
I'm going to try and keep this introduction short because I want to get into the real bolts of this because I think what you've got to say is amazing. But if you can just tell us sort of who you are and in particular the specialty you're interested in.
Yeah, thanks for having me on. I'm so excited about all the work you do as well. Like, you do such great work educating people and giving them really good information. Yeah, so who I am a breastfeeding medicine doctor and I'm a perinatal GP as well. And I'm trying to establish a new field in Australia. It's already established in America. There's a board certified exam, just the way you have cardiology or hematology or family medicine. You've got the same thing there, breastfeeding medicine. And so I've been a doctor for 17 years and I started off my training doing pediatrics for 6 years, and then I moved to general practice. And then it was, despite the 6 years in pediatrics, I had no idea the problems that were in the community until I went into general practice. And that blew me away, that how disconnected we were. And I always like to explain to patients there's a reason for it. So, I say it with no judgment on the pediatric system, because when you're dealing with sick kids, you don't care how they're fed. You don't care about those problems because you've got bigger problems. They're not coming in for small things. They're coming in for really serious things. Sometimes it's a bit of gastro or, breathing issues, but those are serious things at the time. But you're never asking, are they breastfed or are they formula fed? So I had no idea the problems. And then when I got into the community, every day I would have people crying about how, like, there's one mum where I think this is the one that started it off for me. And she said she came in with a 4-week-old and she broke down and she was ready to give the baby, she was in full blown postnatal depression. And it was because she couldn't sleep train the baby. She's like, I don't know, I'm a failure. And this was also before, the widespread information on social media. Now we're talking like mid 2000s or something like that. So there was nowhere to access this information. So she thought, my baby should be able to go to bed on its own. Then I started to see the pattern where it was constantly, myths that was in the issue. And then that's how I ended up going to breastfeeding medicine. And I've done possums training on neurodevelopmental care training in Australia, which is big. I've done the Thompson method training. I've done my international board certified lactation consultant training, and I find they're all fantastic, but we're still missing something. And what we're missing is that the breasts are actually a medical organ, so we need to bridge that gap as doctors as well.
Yeah, I mean, no, it's absolutely right. I said to you off camera, I think, the stuff you're doing, especially on the short form, is amazing. And to us, it's quite a bit of a selfish interview for me as well, because obviously I've got 2 children under 2, and some of the questions I'm asking are genuine questions I have, because a lot of the time, like I said, we're not taught, in much detail about, like I said, the breast as an organ, or how babies are meant to feed or sleep, or what's normal, what's abnormal. You just thought, even for my wife, the baby should just sleep and just feed and latch, and everything, they should grow and have perfect poos and burp all the time and never cry, but obviously that's a far stretch from reality. But yeah, we'll cover all that. But I think the first thing that was interesting you said was about thinking about the breast as an organ. So if you talk a bit about why that's the case and why it's important to think of it as an organ, because I think that underpins the whole of this medicine.
Absolutely, yeah. So I always give where my own failings were in it. And in medicine, as a student, I did not cover the way the breast milk is actually made, the cells. And I did not cover that in pediatrics. I had zero lectures, literally zero lectures in lactation in pediatrics. And the same thing in my general practice training. Did you find the same thing? Did you get any training in lactation?
None, even when so zero, like you, or we may have had a mention in a lecture somewhere. But even when I did speciality training, and even in fact I did a pediatric rotation, where you see, mums, with all these problems. But again, we were never taught, any of this, and I think it's, it's crucial. And and I think and oddly, I've learned all of this stuff just by my own intuition, and and by seeing people like you, which I think is good, but also bad for people that don't have this opportunity, which is why I think it's important to talk about it. But yeah, none whatsoever.
Yeah, and so that's the problem. And when you look at medicine, actually, it's really interesting at how we've ignored the organs. I was doing a set of slides, and actually I was doing a lecture on nipple difference, so with inverted nipples and flat nipples, and why it's actually not a barrier for breastfeeding. And I tried to find an anatomical diagram with the breast, with the areola muscle. I've got my breast ready to bring it out, but this area is the areola here, and this is the nipple, and the muscles in here that will cause that to contract or stay everted. And I couldn't find one. And as you saw when we were off camera, I am not the best at tech. So I was very embarrassed. And I messaged Katrina Mitchell, who's like she's the one who wrote the new mastitis protocol in the Academy of Breastfeeding Medicine in America.
Mm-hmm.
And I was really embarrassed, but I wanted to make sure I got the right images for the lecture. And I said, do you have an anatomically correct diagram with the radial muscles around the areola that leads it to contract? Because it's an erectile organ, right? The nipple can get erectile and lengthen. And she said, and I was nervous about the response, right? And she emailed me back. She sent me a picture from her textbook, and it's on one of my slides there. She sent me a picture, and it was from the diagram from the 1920s. She's like, oh, this is all I have. And she said, let me reach out to my plastics and my other mates and see what I could find. And we came back empty. So we still, today, we do not have diagrams with the anatomically correct diagrams of how and why certain things function in the areola and the nipple. And, you think about the rest of the body, we have so much detail about our skin, like about things that matter for, the patriarchal way we view things. We've got a lot of information, yet the breast as an entire organ are completely not in the medical curriculum. Even last night, I told you I was doing a lecture. It ended up being a lot on low supply. And the only information I have about we're going a bit medical, aren't we? But insufficient glandular tissue or breast hypoplasia all came from surgeons. So they're looking at that just for corrective surgery. We don't have any detailed studies from a non-surgical perspective of breast hypoplasia. And that can sometimes lead to hypolactation, not for everybody. Anyway, I told you just get into rabbit holes, wouldn't I? But
if you could explain a bit about what is the normal structure of not normal, I guess, but what is the important anatomical features of a breast that make it able to produce milk? So from the layers to potentially the glands, and what controls milk production? Because I think that's important, not just for doctors, but also for anyone who's breastfeeding or trying to breastfeed.
Absolutely. Yes. Let me see. Can you see that?
I can see that, yeah.
Yeah. So this is a diagram of the breast. And the way it's constructed is, so this is the pectoralis muscle here. So that's like this muscle that everyone has here, or the pecs that you see on people who really worked it out. And this is fat. These are the Cooper's ligaments here, named after Cooper from the 1840s, 1850s, right? That's where we got all this information from. These are the alveoli, the grape-like clusters. And inside there is where the lactocytes are, okay? Then you have milk ducts coming out here. All right. And then this is the nipple opening. Now, I've also got this breast model, and this is not anatomically correct, but again, this is the best thing I have. So this kind of gives you a cross section here. There's the breast. This is totally going to get banned off TikTok. Every time I have my breasts in the thing, so they're going to ban it. But anyway, yeah. So this is, again, that's to kind of give you a 3D kind of representation of what it is. These are your ribs, right? And then so the front ribs, not the back ribs. And then your chest wall cavity is here. It's where your lungs and your heart up is. Yeah. And then you've got, this is, again, the glandular tissue, and this is the opening out to the nipple. Now, you have about somewhere between 5 to 10 openings in the nipple. Number was all grossly miscalculated. So and that only got corrected in, I think it was the late 2000s, where they did ultrasound studies, and they did further studies to actually examine and understand that there weren't sinuses that were collecting the milk. So we really only started to understand structure in the 2009 to around those kind of studies. So I've also got one of the lactocytes. Okay, but the lactocyte is a small little cell that lines those clusters, those grape-like clusters, and they're the powerhouses of milk production. So these little cells create the protein content, the fat content, and the carbohydrate content. Because another simple question is, where does breast milk, where does it come from? You know,
I guess going to the lactocytes, is it so? Because I mean, this is again something I don't actually know. So this is actually quite mind blowing to me. Actually, so lactocytes in terms of number and size. So, for example, if a woman can't get enough breast milk, is it true to assume she hasn't got enough lactocytes, or is that a completely different kind of issue? Or it's probably more complex than that because it could well be hormonal. But is a lactocyte something that differs in number and size, or is it relatively similar across all women?
so it's such a broad topic. So I can't answer what the actual causes are, but I can tell you that the true medical causes of low supply are not that common. Current data says it's around 5%. I think it might be a little bit higher than that, but most low supply is due to the lack of knowledge about breastfeeding.
Oh, really? Wow.
Yeah, the behavioural patterns. 41% of people, so in Australia, the two biggest barriers to breastfeeding, 46% quit breastfeeding before they wanted to. Sorry, let me just do that again. 96% of Australian women start breastfeeding. 83% quit before they want to. Of that 83%, 40, it doesn't add up, but the 46% quit because of nipple pain and 41% quit because of perceived low supply. And the thing that gets me is that 83% of them didn't want to. We constantly say breast is best, but we're not telling you how to do it. We're not telling you what you need to do. So it's like we're setting people up for serious, mental and emotional stress, right? So going back to the actual gland. So if the glandular tissue doesn't develop in puberty, right? So you're born with your breast buds, then you start to undergo the first development stage at somewhere between 8 and 12. If the glands don't differentiate at that point, there's already an indication of a problem. And there are certain medical conditions where you can see that, certain genetic conditions, and then things like anorexia or anything that can disrupt your hormonal cycle can actually have a difference on breast development. Not everybody. I don't want anyone who had it as a child to think that it's going to affect them necessarily. Then when you're pregnant, that's actually, the breast actually gets activated.
It's important to get that message across. And it's interesting about the fact you said how many women quit breastfeeding because of other factors, not just low supply. Because a lot of time women come in, and actually breast complaints are a massive, massive presenting complaint in general practice in the UK as well. And a lot of the time, the women state is low supply, but when you look deeper into it or ask a bit further, ask some more questions, it tends to be around other issues about taking too long to latch or taking too long to feed, or pain, like you mentioned. And I think that's a real missed opportunity. And also, I think I do feel for these women because society always like you said, it always tells them, look, breastfeeding the best, and it's almost like you're a failure if you don't breastfeed, which is not correct to assume that.
Absolutely.
Because there are reasons why some women can't breastfeed, but also I think it's unfair without giving the women the full picture about how to breastfeed better. And yeah, part of that goes down to how's breast milk produced.
Yeah. And that's where we're at. And the problem is most doctors don't know. I didn't know the depths of the cycle. I'm just getting that diagram printed out for you.
I'm not going to pretend to know. I was going to try and give a rough explanation, but I mean, again, I know the very basics, but I think because again, the basics were just through seeing patients. They weren't necessarily taught to us in that much detail. And I think
people need to understand that it's been left out of our system. Our system has completely ignored parents and infants, and I'm not just trying to get on a bandwagon here, or they're just being left behind completely. And even now, in Australia, we've got such a big push for certain issues that women are having, but I find it so hard to get traction on it, which is why I had to jump on the socials, because I was like, I can't get change in an institutional way, so let me then go and do what I can. I'll just see if my husband, if it's printed out for you. And I didn't touch on the true reasons for low supply as deeply as I would like to. But what the diagrams are coming in. Okay, but what it is it's a feedback cycle, just like the thyroid function, right? So you have nipple receptors, you have nerve receptors in your nipple, okay? Mm-hmm. And everybody has that, male, female, however you identify, everybody has these receptors in the nipple. What happens is when that is activated, it sends messages up to your hypothalamus and then to your pituitary. For simplicity, I just say it goes to the pituitary, right?
When you say activated, what activates? Is it like the pressure of a mouth, like a baby mouth on there, or is it
It's
that
a vacuum. So when
a vacuum? Okay,
it receives
see.
this, but we don't have the answer to
I
what.
see.
I'm doing a research fellowship at the moment, and we're trying to work out what are the actual cells that are sending. Is it mechanoreceptor? Like what is it that is sending? Is it just a simple nerve message? Like we don't know. No one's looking into this. So what happens is that the messaging goes from the nipple up to the hypothalamus. The hypothalamus then receives the messages there, tells the pituitary to produce prolactin from the anterior pituitary, and when you're actually breastfeeding, to produce oxytocin from the posterior pituitary. And now the posterior pituitary, I haven't got a picture of it, but it's kind of like that in the brain, but it actually looks like two testicles kind of hanging down in the brain, and the hormones come from there. Then it travels in the maternal bloodstream to the mammary glands, to the lactocytes. It then binds into prolactin receptors in the walls of the lactocyte. And I think he came back with my lactocyte diagram. Here we go. So it binds to prolactin receptors somewhere over here. So this is the breast, this is the alveoli, and these little purple lines are the lactocytes.
A bit more this way, so it's just a little more to your, yeah, perfect, yeah. I got it. Okay, yeah, I see it. So those, they're the ones, the lactocytes are in the alveoli of the breast.
Yeah,
okay,
the lactocytes are in the alveoli with, like, they line it, right? Like, so, like, I can't think of it now, but it would be similar to a different type of cell, right? So this is the gland here, and then it lines it there, maybe like your beta cells or something. Don't quote me on that.
And the lactocytes are the ones that have the prolactin receptors on them.
And then, well, that's where the prolactin receptors will lock in. Okay.
Perfect.
And it activates the prolactin receptors, and then it synthesizes the carbohydrate content. So I'll go into that more, because I know it must. If someone had told me this, a few years ago, I would have been like, "What are you even talking about?" So
yeah.
I'll explain that a little bit more. So from there, and so this is the bloodstream around here, and this then gets your prolactin in there. Then it will cause you to make the milk, which will get ejected into here. And then it will go down the milk ducts and out through the nipple. So, and this is an example of these are amazing, right? I didn't know about these. These are the myoepithelial cells that surround the lactocytes. That's what oxytocin acts on. And it squeezes it. And it has contractile ability, right?
So, so they work together. This is crazy now. This is interesting, because I always thought, because I always thought it was just prolactin. And oxytocin, we think more about in pregnancy to cause, I'm sorry, during childbirth, to cause contractions, right? That's how kind of, so but it works on the breast, and so essentially the prolactin produces all the good stuff for the breast milk, and the oxytocin helps with the contractions. Yeah.
But we also have oxytocin receptors in the uterus, which is why breastfeeding at birth, if it's possible, if it's not possible for you, don't panic as well. It helps to stop postpartum hemorrhage. So you have a reduced risk of postpartum hemorrhage if you're able to latch and breastfeed immediately, because the baby starts getting that oxytocin released. So other than bonding and establishing breastfeeding, even if you have no interest, it actually helps your uterus to contract and less risk of, isn't it? It's when you go into this, it is mind-blowingly amazing and just phenomenal, but it makes me mad at how even we won't get time to talk to you about, like, the baby blues and what actually happens in that, well, okay, I'll tell you in a second. But yeah, so
no, we cover that later if we have time. And but I think I think the whole mechanism and the anatomy is something that's key, especially for everyone to understand. I guess one thing that I think may well be important to know is, I guess we've got an understanding of the anatomy and the lactocytes and how the initial mechanism, whatever it is, whether it's the the suction on the nipple, starts all this off,
or it's the intraoral vacuum. So fluid mechanics, I got you to get a straw, right? So the fluid mechanics is it'll go from high pressure, negative pressure, to high positive pressure. So just like CPAP, that's essentially how they draw the. Got tools all out on the off camera.
Okay, so I guess while we're on that, I guess we could talk about potential problems in production. Like I said, there's very few medical causes for that to happen, but I guess actually probably the biggest complaint I have is around latch, or how and obviously being a man is it's it's hard to fully appreciate, despite how hard I try, because it's something I'm never going to do. But as to how can nipple shape affect the latch, or what can someone do to improve the latch?
Oh, okay, so much. So let me just get that other cycle one up here. So that's the breast milk cycle. Okay, so I can send you those as well. They're all on my Instagram as well. So the milk fills in the lactocide, and then baby suckles at the breast to draw the milk out. So there's 3 steps. So the way I look at all breastfeeding issues, right? And breastfeeding and lactation medicine is the only time you have to be able to assess 2 people. So even in pregnancy, they're still working as one, In breastfeeding medicine, you have to know how to assess a baby very well, and a mother, maternal issues and breasts. So the way I approach it is it a preglandular cause? Is it a glandular cause? Or is it a postglandular / mechanical cause of transfer? And now you can get a whole range of problems within those 3 classifications, right? So to give you an example, when I say, is it preglandular? If you've had breast surgery or you had a chest strain. I had one mum who, as a baby, had been in NICU and had a chest strain and had severed the nerve supply to the nipple.
Oh,
yeah. And we didn't even think about it. And it's like, why was this particular breast not producing and this breast was? Even in the research, we know that if you've had radiation for cutaneous hemangiomas on the chest, can affect your ability to transmit that message from nipple to the pituitary. So if we have a problem with messaging, that's the preglandular. If our pituitary has an issue, so Sheehan syndrome, a pituitary adenoma, etc., then you will have a problem with sending that message to the breast. If you don't have adequate breast tissue, if for some reason it hasn't developed, then again, you're going to have an issue with producing milk. And then we make people feel like, oh, they're not working hard enough, but there are a few medical things that can make a big difference. And back to that thing about the lactocide needs insulin, TSH, and growth hormone to function well.
It's interesting.
So that's why we see delayed lactogenesis, which is the coming in of the milk, in people with gestational diabetes sometimes, because it's tied back to the insulin function. Told you we're going to jump around. It's so hard to nut this down.
I think you said we need TSH, insulin, and then I think it was just about to say something else. Yeah. Growth hormone.
And they help that lactocide, this guy, that helps this function. So if in something like gestational diabetes, you have your actual blood insulin may be fine, your serum insulin may be fine, but we don't know what uptake this lactocide is having. There is a chance that it's not uptaking as well. So that's why we think we see delayed lactogenesis in mothers with some mothers, not all mothers, with gestational diabetes.
I see. That's very interesting, because this is so much more far-reaching than you would have thought, right? Because this is why it's crucial to have a full history, because normally, firstly, even understanding the breast as we're talking about is one thing, but then linking that into other conditions is a completely different ballgame, and I think that's very important. So,
yeah, you did go ask me about nipple pain there, so I'll get back there. Yeah.
Yeah, I like one thing I'm really keen is what can, say a woman is trying to breastfeed and there really is a true problem with a latch. First, I have to explain what a latch is. You got the straw. I know you've been itching to use the straw and the model, but exactly what a latch is, how it works, and what potential problems can be, and how to improve them.
Okay, so a latch is the latch is the way the baby is able to exert the intraoral vacuum on the breast. Okay, and these are like physics terms, and I'd love for someone from physics to be able to explain it all properly. But basically, the definition of a vacuum is it's created by the lack of air in a cavity that creates negative pressure, and negative pressure enables fluid, in this case breast milk, to motion. So what we're doing is we've got positive pressure in the breast to the negative pressure in the baby's mouth. Okay, so that's a whole lot of, gobbledygook. But I've lost here we go. Okay, so what the key is though is how are you going to get that latch? And we've actually got measurements. This isn't my opinion. This isn't my theory. This isn't something that I've watched a few women and done. I've gone back and looked at the scientific evidence of how fluid transfers. I've gone and looked at measurements of tongue, like vacuum pressures. How does the tongue work in there? So, and we have that information, and we had it in 2009, but it hasn't been translated because, as a clinical doctor, we're very good at clinical but the scientists have so much knowledge that we're not accessing because there's just no communication between us. There's no time, right? Like, so, okay. So going to it, there's a few things that I tell people. Okay. So if you suddenly would you be expecting yourself to be able to carry a big 3 to 5 kilo weight on your hand just over here for 17 hours a day without problems?
Of course, that will cause severe pain or some sort of issue.
Yeah. Because very few of us have developed these particular muscles here. This one, if I can get it to flex up for you. Very few people have developed that muscle because it's who's sitting around doing, you're not sitting there working out this muscle, right? So that's the first thing. If the mother or parent is not going to have that set of muscles established at birth, she's going to need time. The second thing is, as we know, babies have very weak necks at birth, right? They've got no neck control. So this is where I'm going to get my demos to start, okay? Have you got your water there?
I've got water. I don't have a straw. Do I definitely need a straw?
Yeah, we don't need the straw just yet, no.
Okay, I've got water.
Okay. So I want you to tighten up all your crikers. So tighten up all these muscles, okay? Now, so as if you were holding your neck in place. Now try and take a sip of that with this tightened. Keep it tightened.
It's impossible.
Yeah. Very difficult. So you're too busy trying to stabilize your neck if your neck is not supported nicely. If you are having to keep your neck upright and try and latch onto a breast, what you're actually going to be able to transfer from the breast is minimal because all your ability is going into just trying to latch onto that breast. So what is the first key principle is mother needs to be resting back a little bit, like half reclining, and then we need to get the head in the crook of the arm. And this is Robin Thompson has done some amazing work on this. This is what I learned from her. Actually, she's a midwife Dr. Robin Thompson, and she's the one who has very good evidence to say that the cradle hold is the best way of holding them. What a lot of people are taught, and including myself, I was taught this when I was on the postnatal wards, and I used to tell people this, is you shove the baby on the breast. You grab them by the back of the neck and you shove them on the breast. So the next thing I'm going to get you to do, Dr. A, is I want you to put a hand on your neck and push it down a little bit. Okay, not too much, but it's the way we're making shoving a baby onto the breast, okay? Now I want you to get up again and try and swallow with your neck flexed.
Again, you blow my mind here because I didn't even think about these things, but I can see where you're going with this already. It's impossible.
You can't swallow. You're going to splutter. Now I want you to actually take a sip. Let's both do it. We take a sip with our water and watch what do we do with our necks, right? We tip our head back with a little bit of neck extension. So you cannot drink without a little bit of neck extension. And what are we doing to babies? We're going, shove you on this way. You've got fixed line here. So they cannot drink effectively. If they cannot get that vacuum, they will not stimulate the breast milk production cycle.
Oh, wow. Isn't it? Even just that, I wish I'd known this to be able to tell my wife, because with the first baby, I mean, we did breastfeed, but it was quite challenging, and we didn't know any of this. And to be honest, it's interesting that even you're talking about the anatomy and the strength in the arm, how important it is, and then just demonstrating how hard it is to drink when your neck is stiff or your muscles tighten up. And like I said, with babies who've got none of that developed yet, it's almost impossible.
And it always makes me so sad because wherever I go, if people know this is what I do, I will get 70-year-olds, 80-year-olds. I was at a dinner for something at the hospital once, and I wasn't even talking about this, and I had somebody single me out and come and tell me about their story, about how traumatizing it was. So all the parents aren't. That's what's so sad, and it's so simple. I used to diminish what I'm doing and call it feng shui medicine. Like it's a little bit of like hold the baby this, and I do these 4 basic movements. And I can correct most latches. And I haven't met a latch that I haven't been able to take the pain away from. And I've been doing this for a long time now. Like, I think I'm underestimating when I say about 10,000 babies and baby parent pairs, right? So over a long time, I'm super old, right? So, it's so sad that there are solutions here, and I can't get the systemic interest, which is why we're having to do it ourselves, aren't we?
What is the cause? What is the actual cause of the pain? Is it the baby not latching? Is it the suction's not quite correct? Is that what is the mechanism?
Are you ready for your mind to learn again?
Yeah, I am, definitely.
All right. So we're going to be doing, I never wanted to be this person, especially in public, but put your tongue up to the top of your palate. Can you feel how hard that is? Okay, super hard. You may
Yeah.
not want to do this on camera, but if you put your hand to the back, so if I was up here to your soft palate,
Yeah.
it's very soft.
Yeah.
Even if you can get your tongue there, maybe you can get, I don't know if you can do it. Even if you can get your straw, see if you can get your straw, you haven't got straw. But if
I
you'll
can
see
feel
how
it with my tongue. Yes, soft. The soft palate is probably about halfway on the roof of the mouth becomes soft, and then the front half's obviously hard.
correct, very hard. It's a bone, right? So what happens is for most nipple pain, because we are not allowing you to extend your neck, right? And we are not supporting your neck muscles. The baby is like, what's that word? Clamped on like that, right? Then the nipple is going to maximum be in this first part of the mouth. And for pain-free breastfeeding, the nipple needs to be, if you have an erect nipple, it needs to be 5 millimeters beyond the junction of the hard and soft palate. And I've got a diagram here for you. This doesn't have it completely, but these are the essentials for pain-free breastfeeding. So I haven't got my one of where exactly the hard and soft palate is, but I'm going to show you these two. Okay, so this is what we need for good breastfeeding. Okay, and by good I mean pain-free. It should be pain-free for the mother, and I don't mean a twinge. I mean no pain at all. Okay. The nipple gets extended, and don't panic if your nipple's not that long. The nipple has the ability to contract, and don't panic if you have a flat or inverted nipple. It's actually no different for you.
Okay.
It just means that nipple doesn't need to go anywhere. So it will get pushed over to this area here, and you can see the chin is over here, and that stimulates those glands. It sends those messages back to refill. And you've got that little bit of neck extension. These images are from the Royal Children's Hospital in Melbourne, in Australia. So this is an example, and I think this demonstrates it really well. You can see where this nipple is, and you can see where that nipple is. You can see this neck. You can see where the chin is. And I've got these again showing this a lot better on my stuff, but you can see that how that is just going to cause nipple abrasions. So by the position, just like anywhere else in the body, I can tell you where you've had your injury by the type of injury. So if you get nipple tip pain, it means it's abrading the top of it's hitting the hard palate. If you get pain at the base of the nipple, the baby is trying to reduce the flow. But that's a whole other bucket of breastfeeding problems that you may not want to get into today.
Yeah, I guess on that. I guess on that. Firstly, that again, that's amazing. I think, yeah. I mean, already I can just from this piece of knowledge can help so many more women who come in with this, and spread this message.
The Gettys, the studies from 2009. So Nikki Mills, she's a Kiwi surgeon, I think, and she did a really important study on the positioning and the hard and soft palate. And the Gettys Hartman Institute, the Gettys Research Lactation Center, they've got the ones on the intraoral vacuum, and that comes in and has a big impact on tongue tie and things like that. Yeah, but we won't get to that.
No, that's interesting. I mean, so now so we've touched upon about true low milk supply is actually very, very rare. It's normally down to hormonal problems, is my understanding. Now you mentioned just briefly that how the baby can almost reduce the feeding when they want. But I guess one question that women have is if the baby's feeding for too long, and what's the ideal time for a feed length to be? Obviously, it just depends on the age of the baby. But let's say a newborn baby. How long should the baby be feeding for? And when is too long? Because I think that's a lot of and obviously it varies. But is there a kind of a rough guideline you suggest to patients?
So again, it's very variable, baby to baby. But and I think part of the problem, how we got in this situation, is by saying feed your baby every 3 hours for a certain amount of time. But I see a lot of people being told to feed their baby for 10 to 15 minutes per breast. That will not get you, for most people, that will not get you adequate supply in those first few weeks. And that's because, again, the baby hasn't developed the muscles. So the strength of the baby's vacuum increases at 4 weeks. So babies become far more efficient at 4 weeks. And then again, at 4 months, you'll notice a lot of people will come in and say, oh, I'm worried my baby's not getting enough because they're only feeding for a couple of minutes. But again, that vacuum becomes stronger. The pressure they can exert is stronger, and they can do it really quickly and extract that fluid. So
I see.
Yeah. So the general kind of guide, I would say, is that your baby, you need to try and get, for the first 3 weeks, you need every 3 hours minimum, you need to stimulate the breast, and it needs to be around 20 minutes per breast. And I'm only giving it as a guide because we've got to correct the misinformation. So 40 minutes for a proper breastfeed. If we're getting into an hour-long breastfeed, milk is dribbling, things like that, then we need to assess the baby for, are there any other issues? Is there hypotonia of the cheeks? Is there anything going on with the tongue? Is there some sort of palsy post-labor? What is the cause of this inefficient transfer? Is it as simple as latch, or what's actually going on? So the rough guide would be for those first 3 weeks, and the reason those first 3 weeks, I didn't print out my graphs, but prolactin receptors are the most responsive in the first 3 weeks. So you've got a better chance of building your supply. If you work hard in those first 3 weeks, and all caring for babies is working hard, but if this is your goal, if you go into it knowing for the first 3 weeks, you are going to be feeding every 3 hours, you're mentally more prepared. My patients do well because I tell them, and this is harsh, but if you get 3 hours a night with a newborn at any stage, you are doing well. And hopefully you'll get more sleep than that.
I don't think that's harsh. I think that's actually reassuring, because a lot of, because I think women are actually told the opposite of that, and they think, okay, this is abnormal. So I think that's actually more reassuring than being harsh, actually. Now, okay, one thing I must ask you about, came to mind, is around sort of pumping breast milk, and whether one, is that effective, because one, is that as good as because a lot of women ask, is that as good as, breastfeeding, and is the mechanism still the same? So do you still get all the same prolactin, oxytocin release from pumping?
So you do, because physiologically you're going to get the same release if that is stimulated. So most plug-in pumps have a vacuum around 220 millimeters of mercury, and the wearable pumps have slightly less. I've got, again, a comparable about the differences between the two. But for establishing supply, if for some reason you can't directly breastfeed, or you don't want to, or your baby is separated, or you're separated, the best thing you can do is get a plug-in pump. Make sure it's sized accurately, because like I said, this nipple will lengthen and also dilate by at least 2 millimeters on the sides, and lengthen at least 2 to 3 times its length.
So how do you get sized? A lot of the time, which I don't know personally, but I know with my wife's experience, is that a lot of these are off the shelf. So
that's true.
So is it is there sizing on the boxes, or is it like a measurement?
No. Again, so pumps were developed, again, off technologies that were for milking cows. And so, again, they use basic sizes. So a lot of people will find the sizes that generally come within pumps are 24. And people will either be bigger than that or smaller than that. And you can get down, some people have nipple widths of about 13 millimeters, again, it's not the majority, but many people have a smaller nipple widths, and many people have bigger nipple widths. So you actually need to have a look at the sizing. But the best indicator is if your nipple is touching the side of the tunnel, then it's the wrong side, and you are going to have nipple trauma. And we can tell, it's very clear in the way it looks that the nipple, because your trauma will come down the side here. So that's one of the biggest signs. If you get areolar trauma, it means the tunnel size is too big. So the areola is getting dragged in, and then that causes trauma as well. And that's a problem, because that leads to inflammation, which leads to mastitis. So the sizing is so important of the pump. So if you're going to get a pump, I would speak to a lactation consultant who knows about pumping and all of that. And I've got a few amazing ones here in Australia that people can reach out to who do video consults. I'm sure there's amazing ones as well in the UK. Definitely know there's one in Ireland, and there's actually a few. I should have actually got a set of resources for you, but they're all on my socials. I keep pointing to my phone over there. So people can have a look at those people for resources too, and they can definitely help you with sizing. And that's a very important thing as well, because it's not so important. I think UK and Australia are pretty good for paid maternal leave, or paid parental leave, but the States, we're seeing so many issues because, those people have no options. They just have to start pumping because they're back at paid work, at 4 weeks. It is paid work because caring for a baby is work.
Yeah, no, I definitely agree with that. In fact, it's probably harder than actual work, some would say, because
Look,
there's no
yeah,
break.
yeah. When I go to work, and I love being home with my kids too. Yeah, but
Yeah.
yeah.
I think one thing, is there any evidence of, or anything about, I guess this is just maybe just a question that's come to my mind again now, is about mental health and development in terms of benefits of breastfeeding for mum and baby. So, for example, if a mum breastfeeds, does it help? For example, with postnatal depression, or can it prevent that, or can it help with, does it help release with dopamine and things like that? I know there's some theories out there saying that it can be the case. So, to help you get through with breastfeeding can obviously increase the bond for baby and mum, but also help maternal mental health.
So definitely, and there's very good and clear data here. And I want to be careful in the way we deliver it. So we know that biologically, physiologically, breastfeeding releases things that protects mental health. If that doesn't happen for you, there's usually pre-existing mental health issues that are brought to the fore. So what I see is a lot of postnatal depression and postnatal anxiety. A lot of these people have been missed. And then you throw this huge life stressor at them. I know it's a joyful event and everything, but the actual practicalities is it's a huge life stressor because it's not just the baby. Your relationship also goes through a big shift. I always tell people, and you met my husband, like we've got a great relationship, but I always tell people that if you also don't want, I do say this, if you don't want to get divorced at some point in time in the first 5 years, someone else is probably raising your kids. And we've been together, I think, almost as long as I've been a doctor. I think 17 or 18. I don't know how long we've been together.
Congrats.
16. Yeah. Look, some days it's iffy, Today he helped me with the tech so he can stay, but
yeah.
No, but in general, there's so much that has to happen. And it's like adding a third person into your marriage, and people weren't expecting that. Then people start re-experiencing their own upbringings. And that can be traumatizing for a lot of people. Even if you have the most wonderful thing, people start re-experiencing things. So maternal mental health, we need a look at it. The Edinburgh Postnatal Depression Score was good for what it did at the time. We need more. So every aspect in this postpartum care is just not adequate. And I don't want people to feel hopeless about that. We need to push all the governments all over the world to put better emphasis, better funding, and better money into it. So in answer to your question, breastfeeding is protective for mental health. We know, especially for the first 4 to 6 months. If that didn't happen for you, there's usually some other problems. Now, there can be things like, I don't know, have you heard of dysphoric milk ejection reflex, the DINA? Yeah. So that's one where we, again, don't know the mechanism, but that can lead to extreme feelings of doom and anxiety and awful feelings. And that can massively impact mental health. If you can't, there's so many interplaying factors here. But then there are patients who have pre-existing mental health issues. I often say sometimes they might need the space. Maybe they pump, maybe formula feeding and bottle feeding is a better option for them. And I'm always amazed because I give them all these options and I say, look, we say all this, but what's most important for any baby is that the parent, the primary caregiver, is well. That's the most important thing.
Yeah.
But so many of them, I'm always surprised. I'm like, I'm really worried about, with quite serious mental health issues, depression and anxiety, but other things as well. And they manage it, and they actually find it protective for their mental health for the first 4 to 6 months as well. Now, that won't be the case for everybody, but for a lot of people, the actual science is that it's protective. The actual experience may not be, but there's many contributing factors. So mental health, well, I'm talking just physiologically. Did I make that?
I think, well, now we're on that topic, I think it's a huge topic is, the maternal mental health. So I guess specifically, what is the difference between postnatal depression and the baby blues?
Okay. So the postnatal depression are when the symptoms last for longer than 2 weeks, and there's a whole range of symptoms. It can be lack of joy. It can be not getting up in the morning. It can be a disconnect from your baby, but the symptoms have been there for 2 to 4 weeks. There's a huge range of how you feel there. But I've had many patients, the figures that we see, to me, are grossly underestimated. I don't think it is in Australia, we say it's 1 in 5 mothers or AFABs and 1 in 10 fathers. And I definitely know for the parental point of view, I will say, I think you have this, you may need this. And parents don't refuse it. So that won't, or they don't want to take the medication, or they don't want to go for the therapy, or there's no time to look after their health. And then they won't be counted in that data. But your question was, hang on, I lost it there. I started to go on.
Yeah, so I guess because sometimes it was because sometimes the lines can get blurred. Now, again, back to a quick note on that, I think you're saying the figures are underestimated. I think they are now, but I think if you look just generally throughout human evolution, we've always been in like extended families. So so it'd be like mum, grandmum, aunties, cousins, nephew, everyone would be living together. So the number of caregivers would be far more, and so that means mum can have a break and baby can be looked after. But now it's more like nuclear family. So to mum and dad and baby, there's almost and dad, or the primary breadwinner will go out to work, and the primary carer, whoever that is, whether it's mum or dad, will normally look after baby, and there's no break. And I think that has and I think that's often underlooked. And I think that is and I agree. That's why I think the numbers are far higher than what the studies state. Because a lot of the studies are done, they're not new studies; they're relatively old. Right. And I think that's one big factor. I think I think raising a child now is far obviously it's hard to say, but it's just from a pure health point of view is far harder, more of a challenge than it was for previous generations. Of course, they had their own challenges, but I think now when you've thrown social media, no lack of support, I think it's more of a challenge, and I think that's the reason why I agree. I think it's going much higher in number. But yeah, so to go back to your point, so disturb you was about how can someone know.
I actually think that's a really good point, and I think that's a really important point to talk about too, because the lack of support is huge. And I'm an introvert, so I actually quite liked being on my own. But by 3 p.m. every day, I was like, I need someone else. And I really love babies. I was doing, all of that stuff. But it's a lot to be sitting there on your own every day. And some people don't know. They may not know what they're doing. I always tell patients, I was in peds. I knew all these things about babies, but I was overwhelmed because of the maternal brain changes that occur. We get new neural pathways in our hippocampus and our amygdala. So, again, there's so much going on, but culturally as well. The nuclear family, I always say it, I don't know if socials is the right place to say it or a podcast, but I think the nuclear family for child rearing just makes no sense. 2 people with kids, it's you need more people. The kids also like having other people around. I of course love my parents; they're amazing people. But I don't understand why my kids will choose to go to I'll say, do you want to go to the beach? Do you want to go to your friend's house? Do you want to go ice skating? Do you want to go do something super cool, or do you want to go see your mama and tata? And they'll say, let's get out, and they don't do anything there. And I didn't have my grandparents around when I was growing up here, so I don't understand what they're. I don't get what they're doing, why they even like going there. But clearly there's something with why kids sounds a bit crazy, but obviously there's something in that natural kind of grouping that they tend to like. And every kid, it won't be like this for every kid, but definitely it's not just about the company. We lost that knowledge, so even when my sister had a baby, she had me and my mum to kind of help her when she encountered problems. Because I thought, was it my Indian culture which made things go pretty easy for me? Or was it, and I think it was actually just being around babies. I was around babies all day at work and small babies. So I knew how to hold them. I knew how to do different things. And my sister had a few issues and she had, she'll ring me up, be like, oh, what should I do for this? What should I do for that? And she had that backup. Whereas a lot of parents don't feel comfortable asking others for support. Maybe they don't trust the advice they're getting. Even today, I had someone reach out and say that on day 2, her mum was saying, give your baby formula and she really wanted to breastfeed because that's what I gave you. And then I said, look, your mum's trying to do the best by you, but it's probably because that's what she was told. And then she went back to the conversation. She said, yeah, that's right. My mum was told that was, that we had to do that. So there's so much this cultural aspect, but yeah, we could talk about that.
Yeah, no, I think it's tough. It is tough for, I guess there's 2 aspects. One aspect is, for example, my son got unwell last week and his grandmom was like, it's tonsillitis, just straight off the bat. And she was right, and I think that knowledge is important, is key. But then there are limitations and it can be tricky. And also for a mum, it's hard to know, okay, is what they're saying right for my baby or not, and I think that's where it gets confusing. And I think that's where we as clinicians need to kind of give them that advice, and say, look, this is probably the best thing. Ultimately, it's your decision and what works for you. But it's different for everyone. What we suggest might not work, but I think it's being open and saying, look, you could try this, is probably best right now. And then you can always come back and see, if it's working or not. But yeah, going onto the point about
baby blues.
So how can someone know? Because baby blues are obviously huge. I don't know the exact figure.
80%, more than 80%. There was a recent 88%. 80% of people will experience the baby blues. And what happens there is it's a huge emotional shift. But what actually happens physiologically to you, and it relates back to lactation, is, I haven't got that graph there, but the placenta is producing your progesterone, your estrogen, cortisol, human placental lactogen, HCG, or a whole bunch of things. And it's when the baby is birthed, that's one thing. But when the placenta is birthed, you have a huge drop of these hormones. Again, I did the graph yesterday for that lecture, and I could see people were like, because the progesterone has to drop, because progesterone inhibits prolactin, right? So, and going back to our low supply causes, if you have retained placenta, that placenta will be producing progesterone, and then you don't get that, you don't get that rise in prolactin, and which is why one of the few medical causes of a low supply is a retained placenta. So anyway, I went off track a little bit there, but what's happening when people are having the baby blues, and I don't like that term because it dismisses the shift that's happening. It's these hormones are plummeting, and at the same time, you're getting a whole new hormonal cycle working. Your breasts are getting engorged, and they're rock hard. They inflame to a point where they actually feel like, you would have heard that description, like rock hard, breasts. And it's because this tissue has never been activated before. So as that gets activated, you get this extravasation, you get this congestion, and that's what causes the engorgement. And it's physiologically normal. I can't tell you how many people are terrified of their breasts because, we've only seen the breast as an organ of objectification, right? Not as functioning gland that reaches maturation after lactation.
Yeah, and that's a good point. And I guess with postnatal depression that you mentioned, what the difference is there, but does that put women who have got that at high risk of sort of mental health problems, for many years, or do most patients with postnatal depression get better? Because I know a lot. This is another tricky one as how to treat it, because obviously antidepressants are an option, but I'm of the impression, it's probably best avoided if you can, because just because of the nature we work in, is seeing patients regularly is very, very difficult. So by the time you put them on antidepressant, they're normally just stuck on it just for such a long time.
Absolutely.
Which is not, in my opinion, not the right way to go. So yeah, I mean, what your experience? What do you think about that in terms of patients who have got postnatal depression and them getting long-term depression or anxiety, and what is the best way to treat their depression postnatally?
So I definitely feel that the lack of support and their postpartum experiences, and I think there's data to support this too. What happens to you in those first 6 months dictate what your maternal mental health is going to be like for those first 5 years. So I see that in my patients, even when they're past that lactating point, a lot of them want me to keep seeing them because they've built this bond, because we don't have the community, and their maternal mental health does stay affected, actually, especially if they weren't able to meet their goals. You're disempowering people at such a crucial point of their life. That has an impact on their self-esteem. The people who will say, what they say to us, what they say to us is very different to what they say outside, right? So just because the strongest person is like, oh, I was fine, this happened to me, doesn't mean that it's not affecting them, internally. So your question, though, was how's the best way to manage it? I find that there are so many patients that with explaining to them what's actually supposed to happen, what's normal with baby sleep, what's normal with baby crying, that it will get better, that it won't get better, that, that it's going to take, that the pineal gland only matures at 24 months. So baby sleep can be very bumpy for 24 months for some people. Explain that there's no evidence behind other sleep methods. Everybody should do what they need to do. There's not one right way of doing it. And so taking away that burden of you're doing it wrong, makes a massive difference for their mental health. And sometimes that can be enough to avoid further treatments. I see some people who are put on things that I think was possibly inappropriate. I also definitely do see some people who, and I often see it's people without the supports. Sometimes they do need the medication and they improve. And especially if they've had a traumatic time, if they've had a baby with reflux disease, cow's milk protein, a premature birth, something like that, they can need that extra support, because the way I say to them, and I don't have many, and most mums don't want treatment as well. They don't want medication. That's the other interesting thing that's left out of the discussion. Parents don't want external things when they're looking after babies, even if they're not breastfeeding. They've I think we were talking about that at the beginning, that everyone's moving towards a more natural way of things. So I don't have data on how many people I would do that, but if they haven't got support, I'm more open to it. But at the same time, when they've had a reason to be anxious and have a lot of anxiety, sometimes the escitalopram can make a little bit difference. All it does is just calm the noise. But these people also often have pre-existing mental health issues. So, it's a tough one to kind of do, but I think there's a gap that we're not covering. There is postnatal depression and postnatal anxiety, but we haven't looked at data, and I don't know how we could, because a lot of them aren't diagnosed till they come to us, with it. So it's such a complex topic. For trying to be clear, I would always go with CBT. I have some great psychologists that it's actually amazing. When those psychologists are on holidays, I find my patients all have to come and see me more. But when they're like, they don't even need me, because they've such good support from this particular psychologist.
Yeah, I think so. I think that's what. So even now, when we say mentions, firstly, I think managing. I feel like when someone comes in, a woman comes in with depressive symptoms and they're postnatal, they almost get dismissed and say, "Look, it'll get better. Just cope with it." Firstly, I think that's wrong. And secondly, I think the key thing is CBT and psychologists. And with us in the NHS, that's one thing that's lacking. Because when you say CBT now, it's almost like, oh gosh, that's a negative thing because it's not good. But when you actually get good psychologists who know what they're doing and the same one following you up for a long time, it genuinely does really help. But trying to get that message across in a system where those resources are lacking is really hard. And that's why I think patients get, they're like, I've tried. Because at the moment, I think the one we use in the NHS is essentially just a phone call. And, if it fails, most times women will come out saying it's failed and then they get started on antidepressant, which is not right.
Wow, really?
Yeah,
straight away.
So it's very, I mean, I see it all the time, and often they'll come in many years later on sertraline, citalopram, not even escitalopram, it's a citalopram, and why did you start this? They're like, oh, I started it, way back when I had my 3-year-old, and it's and I'm still on it. And then obviously trying to get them off it is a nightmare because they've been over 2-3 years. And I just think that first decision to start somebody an antidepressant should be taken really seriously.
It should be.
Yeah,
absolutely.
And I think it's not. So now on that, one thing is I guess is mum brain a real thing?
Oh, yes. Did we go through that? Yeah. So mum brain is absolutely a real thing. But again, that's another, you see all the terms that are used to refer to what we experience. Mum brain, baby blues. What else? Like morning sickness, right? It is debilitating. I had it, and I had no idea. I remember when I was in peds, I was like, surely being a mom can't be as hard as nights, right? But and then you realize just being pregnant in that first trimester sometimes can be awful. So, but you asked me, which one was I before I went on my rant? Mum brain. Oh yeah, mum brain. Yeah.
Mum brain, yeah.
Yeah, mum brain, it is a thing, but it's a protective thing and it's an amazing adaptive mechanism. Okay, so what happens is we get neural changes, new neural pathways, and there's a really good book called The Nurture Revolution, The Nurture Neuroscience. There's a PhD neuroscientist. Her name is Dr. Greer Kirschenbaum, and she has a really good book about all of the changes that occur in this, and it's backed by evidence. So, but what happens in especially in those first few weeks after and up to 6 months to 6 years, what's happening is you are getting those neural pathways, but also you also lose, I think it's grey matter volume. I have to double check if it's grey matter, but you lose a different volume there, but you're being replaced by these mechanisms of how to care, and it helps the baby. So it helps that survival of that infant. And this example I always give, now this isn't backed by evidence, this is my personal experience, but before I had kids, I wasn't sure I was going to have them. Hopefully my kids don't see this. They hear me saying it all the time. But anyway, I was a very fun, exciting, adventurous person. Any adrenaline activity you could name, I did it and I loved it. My husband's the one who wanted to have kids. We had the kids. And then when my oldest was about 5 months, he's like, oh, let's get the kayak and go for a kayak. And I was like, yeah, that's something I like to do. Sure. So I got the carrier, ate in the carrier, went down to the bay, and it's in, mind you, knee-high water, right? And a massive panic. And I got in. I was like, no, take me back to the shore. Nothing was wrong. I just could not calm down. And I was like, no, I just need to get back out here. And even now, I've done everything, so in this little bay, we do have some sharks. I know that's crazy for people from the UK, but there are sharks that can come in here. But I've gone diving with great white sharks. I've swum in the harbour where there are sharks. Not a bother on me. Ethically, I now don't think that's the right thing to do. But anyway, I did all of those things. And then I panicked in this knee-high water where there were no sharks, being like, oh, there's going to be sharks. And that's an example of how my brain changed. Even there's so many things where I started, even when we go to the beach, I would be sometimes surfing, sometimes swimming out, past the wave. Now I'm like, I'm too nervous about it. It's something you always have to try and not show that to the kids, but that's the structural change, that that protection drive. It's not me. It's not my personality. That's not who I was pre-kids. Yet that's where I am now. And that is, I told you, so you can cut all this out if you like, but there's so many examples of that, of ways that parents will change. And then you're getting this message from society, oh, you should still be who you were before you had your baby. But your brain has structurally changed. You can't be who you were before the baby. You may like some of the things, but I mean, even like reality TV, I would have been horrified if you see some of the nonsense that I would watch, like these, what is it? The Sunset, whatever the reality real estate show is. Before I had kids, I would have been like, no way. Now I'm like, oh, when's the next season? I'll talk to patients about it. And I'm like, please don't judge me,
No, no one's going to judge you on that. But it's amazing because, I guess once you're a mum, you're always going to be a mum. So that protective instinct is, and to us, I didn't know that, so that is, and that's another thing to me because mum brain is a term that is thrown out there and it's often seen as a negative thing.
It's diminutive. Yeah. So in the same way, you can pick up different things, the same way something's off on my kids. And Dom's a very intuitive and very present dad, yet he still just won't say. I don't think it's because I'm a doctor, it's a mum. And the same way he'll call me up and be like, should I give my kids Panadol? And I'm like, the billion mothers out there can work this out. I'm like, I'm sure you can work out the kids need Panadol.
No, it's interesting. Honestly, I think that's something that, again, mums need to be aware of, because even mums themselves say, oh, it's just my mum brain, but they shouldn't really be putting themselves down like that now. And I understand why, because that mechanism will never leave, right? For example, even in the animal kingdom outside of humans, you can see that happening, that instinct, like bears, for example, when they're running their cubs, or if they get really protective, there's a similar sort of thing in that, that protective mechanism is always going to be there. It makes sense, right? Because you need to look after your child, and those things, like your example about going in the water, it was like, this is dangerous, get out of here,
Well, and I can even do another example of other mammalian species, again, an experience. I went, with all the adrenaline stuff that I used to do. So I worked with lions, and you cut this out because this is the bit that'll make me seem unhinged. But anyway,
keep it if you want. It's up to you. I was quite interested, sort of, carry on.
Okay, yeah. But then, so with lions, and then also with mountain gorillas in Uganda, I went and did where you walk with them, and it was amazing. But what was really interesting is the mums had babies, and they would not let the males in the group near them. So I was sat across. You can't see where I am now, but maybe a meter away from a mother gorilla. No, that's a bit of an exaggeration. It was probably about 2 meters away from a mother gorilla and her. It was a 2-year-old, and then she had a 5-year-old with her. And another bloke in the group tried to come up close and sit, and they all snarled, and the silverback actually beat his chest and was like, no. And I'm like, they can somehow sense, the difference between anatomical, not getting into the gender things, but, between the anatomically, like, women and men. And with the lions, I'll tell you that story another time. But basically, I had a lion territorially pee on me. Yes, which is fun.
Really?
Yeah,
What?
yeah.
So yeah, please do tell that story. Yeah.
Yeah. So actually, from a medical point of view, this is super interesting. So lions actually have, you know how we have HIV, they have
Mm,
FIV, which is feline
mm,
immunodeficiency virus. And
mm.
so these ones were kept separately. And I was doing a part of a rehab thing there. So I was we clean out their cages and not cages, what's it called, their areas. And so you have to clean away the poop and all of this kind of stuff. And I had two mates that were also in the area, and me and my friend, we were rostered on to clean out the compound. I've forgotten the right word, but we were rostered on to do that. And so we were shoveling away, and our two bloke mates came up to say hi, and the lion just lifted up. They have a different way of territorial marking, is different to peeing, and they just did that straight on us two females, which is.
I didn't say stay away, don't come near. This is my territory. Don't cross this border.
But we're cleaning.
Mm.
It's not like you've got to keep this one out of this.
How? That's quite. I mean, that's quite brave, because I would have thought they could have easily done a lot worse than just peeing on you. You know, so it's
They
an
were
interesting
behind
story.
another thing, so they weren't in
I
there.
see. Okay,
Yeah,
okay, good.
I left that part of the story.
I thought you were like there was no barrier between you and the lions, though.
Well, we did that with the other lions that we were working with, but these particular ones had to be kept separate to the other lions. Otherwise, they would transmit the FIV to them. But yeah. But
Okay,
anyway, going
good.
back to where was it? Mum brain. Yeah. Okay. So
Yeah,
start
yeah,
again. Yeah. So with
yeah.
the
No, no,
mum,
no. Sorry, carry on. Yeah.
all I would say with the mum brain is the reason why it's important to know that I call them the postpartum maternal brain changes, are enormous. And your brain is getting restructured, reshaped, and you are metamorphosing, which is also why I don't like the word matrescence. It's not a rebirth, it's a re-transformation of a parent. But those changes don't stop at 6 weeks. They go up from at least 2 years to 6 years. And it's really interesting because you see what I notice in parents is there's certain points where they get this confidence. And the first one is at 3 weeks when they're used to holding their baby. They come in and they look different. They've changed, you know. And then another point is when their first child. I used to think it was something to do with school. And then when I found these studies, I was like, no, it's actually that your brain changes settle. And when your first child is somewhere around 6 or 7, those changes settle for a lot of parents, and you become more comfortable with everything. So yeah. So
I think going on from that,
know that it'll come right. That's all.
I mean, no. That's an important message to know, because I think the question is, okay, am I going to be like this forever? Is it normal, and when will it end? So I think that's key. And I think one big aspect I think we do need to talk about, if you can please, is around baby sleep and sleeping. Now I know this is a huge topic. In some aspects, bigger than even the feeding topic, but I think that has such an impact on mental health. And I think along with feeding, it probably causes the most distress and so many questions and so many so many different advices people are getting about, you know, how to sleep, should you sleep with your baby, when to put him in a cot, you know, don't hold him to sleep, hold him to sleep, all these questions. I think I'd start with sleep in particular. Is the first one. The question is, when should a baby be sleeping alone?
Hang on, it's cutting you off there. It stopped after when should a baby be sleeping alone?
So when should a baby be sleeping alone, ideally? Yeah, I know it's a hard question, and I appreciate you've got so many nuances to it.
Yeah. Look, the idea, I always put it to people with sensitivity. As adults, do they want to sleep alone? Or do you want to sleep with your partner in a bed?
Yeah, most of the time, yeah. Most of the time, not alone.
Most of the time,
yeah.
right? Like,
yeah.
So when should a baby be sleeping alone? Let's talk about the science, then we'll talk about how we all have to adapt to this modern way of life, and then we can go talk to it. So when we talk about the science, the physiology, there is no scientifically based answer, and there is no evidence that a baby ever needs to sleep on its own. Should everyone come for me now? But basically, there is no science to that. It doesn't have any impact on the child's development. It doesn't have any impact on the independence, on the cognitive state. It has no impact upon the child's ability if they are sleeping alone or if they are sleeping with others in a separate sleep space or in the same bed. There is no evidence, and I don't think we will ever find evidence, because I don't know how you would do a study which could truly be robust about. So that's the first thing. That's the science. The reality is, when we have to go to paid jobs and we have to leave the house and do things, we need different energy levels. And even if you don't have to leave the house, even if you get to stay and, do work in the home looking after your family, then you still need some sleep to drive, to do all of these modern activities. So what we need to do for practical reasons is a separate thing. But there's no scientific basis to the idea of a child sleeping alone. So that's that.
That's interesting, because I remember I've seen it quite a lot of social media statement where I can't remember who it was and whether it's even true, but saying that but babies ideally should sleep with a parent until the age of 7, and this can help with separation anxiety, it helps with mental health, depression. I don't know whether that's true or not, but certainly the rates of anxiety, depression in children is through the roof. I mean, there are some things linking it down to the lockdown and you're being locked away for 2 years. Obviously I think that's been a big detriment to children's health. Also, is there something more than that? And is there something more to the modern lifestyle in terms, in particular, about being forced to almost sleep alone because mum's been told that's the right way to do things?
And so I only talk about the evidence. So I have a lot of opinions on this. And from looking at
Please do give your opinion. Obviously, there's evidence, but yeah, I think opinions are important.
Okay,
but of course,
all right.
You
Okay.
both. I think it's important to hear them.
All right. My opinion, I don't like to give my opinions when it's not backed by evidence. As in this medium, right? My opinions are that when I've done a deep dive as well into evidence as to the rates of mental health in cultures where they are around people, and there are a rake of problems in cultures where they are in big communities too. I'm not denying the problems that exist with close-knit, extended family communities as well. But there is, the rate of suicide, child suicide here is, I don't even have the words for it. I was reading about a 10-year-old who killed himself due to the bullying. And of course, we can't attribute that back to the fact that the baby was sleeping on his own or anything like that. We'll never be able to tie those two things together. But the way our society has cut off and on false ideas of independence and development is harming children, I think.
Yeah.
Mum's mental health or primary caregiver's mental health always has to come first. Sometimes you just can't put up with the baby crying, so fine, let them sleep alone. But if you're doing it because you think that's best for them, I would say rethink it and really delve into different types of theories on attachment and on being responsive and on different caregiving. And again, you know how we're talking about mental health support. If you can't access good psychology sessions, if you can't access because of cost or because of where you live, there are a lot of things online now. Like I told you, I'm older. I had disdain for everything that was on socials, but I realize there's so many good resources out there for people who don't have access. Even what you and me are doing, the people who can't afford to see doctors, they can get access to good information if they choose to, come along with us or not. They've got access to it. So where did our trend topic start there? It was about.
Yeah, so I was going to say, sleeping alone up, so it's interesting there's no scientific evidence, because I think modern society now is almost like if a baby doesn't sleep alone, you're doing something wrong.
And even this independent room thing, where does it come from that a child needs its own room? Like children, there's so much bonding to children, like being with people for a longer period of time. Like this idea of they need their own spaces and things like that there's no evidence to support it. There's no evidence to support what I'm saying either. Well, there's different psychological theories, but there's no evidence to say that a baby should be sleeping alone. And we know, I can tell you the evidence from a scientific point of view as far as infant brain development goes. So firstly, you don't have the circadian rhythm until at the earliest 4 to 6 months. So unless you have a mental health issue, I would not be thinking about more extreme methods like crying it out for an infant until.
So I think that's very important, actually, talking a bit about the circadian rhythm, the pineal gland, in particular in newborns and when it develops, because I think that underpins a lot, actually, and it'll clear up a lot about when to sleep alone and when not to, etc.
Yeah. So our guidelines in Australia are that the infant should be in the same room until at least 6 months of age. I actually think that it should be longer, but it should be in the same room in a safe sleeping space. for the first 6 months of the baby's life. And it actually helps both parent and baby. And, I come from the medical field. I had no idea how I was going to do things. And we are brainwashed to be anti all this kind of stuff. And you would be amazed. High profile doctors, surgeons, obstetricians, pediatricians who have come to me and been like, oh, really? Should we? I'm surprised that I actually did this with my child instead. So we'll follow the thing, like baby needs to be lying on their back, and they need to be in a safe sleeping space. Look at your own country's guidelines for that. I'm not sure what it is in the UK, but in Australia each state has their own guidelines, and we have the Red Nose organization. But, we won't talk about the SIDS and the like sudden unexpected infant death and things like that at this stage. But this is just about the theory of how babies should sleep. But basically, the first thing is the circadian rhythm doesn't develop. They don't have that development at the earliest until 4 to 6 months. And because we're talking about breastfeeding, let me tell you an amazing thing there, that the breast milk has tryptophan in it. And tryptophan is, guess what, a precursor to melatonin and serotonin. So when parents give that to their babies, that helps them create their own melatonin and sleep better. So anyway, that's a little side fact. And that's at 6 months. That's the first kind of formation of it. But a lot of parents will note that between 6 months and 10 months, and we do have studies to show that whether they're formula fed and sleep trained or whether they're breastfed and co-sleeping, the babies wake the same amount. The way the babies respond, and I've got that study here, I printed that out in case it's in my paper somewhere. The babies wake the same amount. What they ask for from their caregiver is different. So the babies that are sleep trained don't necessarily call for assistance or comfort. They just go back to sleep. And some people think that's amazing, and you're entitled to think that, but it doesn't give your child any advantage. And that's what's really important to know, I think.
And on the topic of melatonin, what is your thoughts on, it's different in the UK, but I know, and in the States, I'm not sure about Australia, is about melatonin, in particular in children, because a big problem in, not newborns, but you say 2, 3, 4, 5-year-olds who aren't sleeping and are getting, in America, you can actually buy melatonin without a prescription. In the UK, thankfully, it's a lot more regulated and you can't have it without a prescription. In fact, you can't have it in children without a specialist prescription, so with a peds consultant. But yeah, I've got my own opinions on it. So what are your thoughts on melatonin, in particular in children?
So there are some children that do need it. So that we'll go to those first. So kids with certain types of epilepsy, certain types of neurodifference, certain types of neurodevelopmental disorders, ADHD, ASD, sometimes they need help with sleep regulation. Certain people with different types of blindness, if they haven't got the ability to receive input into their pineal gland, then so they might need it as well. So there are some cases where medically you might need it. But the evidence, and I think it's, again, we're solving a cultural problem with a medication, which I'm seeing so much in my space. If you've got low supply, take this medication. If you've got, a plugged duct, take this. We're approaching it incorrectly. And you'll always find a group of people being like, oh, it worked amazingly for me. Melatonin in children, without a cause, I would be very hesitant about it. I don't know if it causes any damage, but I don't think it's beneficial for them. But that would be my general way of practicing. And I always say that to my patients. That's how I practice. If it doesn't agree with you or it doesn't align with you, please find someone that does align with your values. But my general opinions on that is we should not be doing that. Especially, I think, for us, our guidelines are not under 8 years,
Yeah, I agree. In particular, in particular in children, I think I agree. I don't think melatonin should be, unless they need it, like the condition you mentioned. But I think it should definitely not be bought as a supplement, or it should definitely be treated as a medication, because I think what a lot of people don't realize is you're suppressing the natural production of melatonin. So you get to the state where you need more and more dosage because your natural melatonin production is, getting less. And we don't know the long-term harm of that, and so I can't say it will cause you harm. But I suspect, and my suspicion is, that definitely going to be good for a whole barrage of, mental health and neurodevelopmental conditions. And I think that is something that's overlooked. Just because you're giving something, the child sleeps, doesn't mean you're doing. For short term, I don't think it's an issue. But again, a bit like the mental health and medication, children are on it for many, many years, which is not right. But yes, I just wanted to ask your opinion because I thought it'd be the same as mine, which is good, I guess. But it's important to know. So, yeah.
There's so much, we just have to wind it back and look at why are we approaching it that way. And I think as well, because we lost the parenting skills as a society, so we sometimes have to, and again, with no judgment, it's not any individual's fault, anything you're struggling with, it's a societal problem. Just even how to play with babies, how to read. So many babies I'm finding are not developing their neck because people don't know that you've got to hold them up and give them an opportunity to try and use those. It's not just tummy time. They need that if the baby is batting at something, that's playing. They don't have to be able to grasp it straight away. The way they develop those muscles, is through playing. So yeah, it's a huge, huge problem that it makes me very sad because there's just a gap in those parents feel so they don't know what to do. They're at their wit's end, and
I agree. It's almost like you had a baby. Here's a brand new human. Go home and just deal
go
with
home.
it.
Deal with
And
it.
see what happens.
You feel bad that you don't know how to deal with it. One of my friends said to me, she had such bad postpartum depression and she was one of the first to have kids. And she's like, I thought it was going to be like a Huggies. Huggies is a nappy brand here. She's like, I thought it was going to be a Huggies ad, like a baby running through a field and like a dog, And she's like, it was just brutal, like realizing what it actually is,
Yeah. One thing while we're on that, on topic of we're on the topic of sleep, is it's been a hot topic recently, a very controversial one is co-sleeping. Obviously there are big dangers about co-sleeping, but also there are ways to do it effectively.
Correct. And we need to talk about it as doctors because people are doing it unsafely. And when you look at the data of the deaths, they're actually equal between, I can't remember the exact percentage, I think it was 41% in the study I was looking at, were from co-sleeping, but there was still 60% that were in safe sleep environments. And some of the ones that were in the co-sleeping cohort were, I think more than half of them were unsafely co-sleeping. We need to talk about that. Yeah.
So what would constitute safe co-sleeping?
So I have a handout that I give everybody. And again, I think you can sense my hesitancy to talk about it, right? Because
I get that because it's very controversial. And I think out of everything we talk about, this is probably the most controversial actually. You wouldn't have thought that, a couple of years ago. And I think there have been a number of deaths, high profile deaths with co-sleeping. Please do, give your opinion on how, because I think people are doing it without the right advice.
Exactly. And that's what we know. So we know that we need to discuss it so that people do it safely and that they don't feel like they're doing something wrong. Whenever I bring it up with my patients, I ask them, how are you sleeping? And I don't put any kind of imposition on them. And then I say, okay, well, if I'm just going to give you this handout because if you ever find yourself in the situation, like I think it's 83% of people that find themselves doing it unsafely at some point, this is the information and then they always will confess to me that they are co-sleeping, or they bring their baby in at 4 a.m. because you get the cortisol awakening response that happens at 4 a.m. So the baby is naturally more awake. So they're bringing their baby in anyway. So my advice is keep the baby flat, lying on its back. Keep it on, it needs to be a firm mattress. You're supposed to have the baby on one side and not wedged into a wall because they can get stuck there. And then if there's two people in the bed, you both sleep on the other side. People tend to like to sleep with one person this side, one person this side, and baby in the middle. But according to the guidelines, the safest way of doing it is with baby on one side, parent, mother or breastfeeding person on this side, or formula feeding person on this side, and then the other parent there. I add an extra element in, and I get my patients, and I made my husband do this as well. Sharing what I did. But he's 6'4", he's tall, but I said, we're going to come halfway down the bed and we're going to put the baby up at the top of the bed so that because I like to bring my blankets up, and I was just too nervous about that. So, and I often find that at 4 months, it's a different conversation because patients are more familiar with their baby. So in cultures where we're not familiar with babies, at 4 and 6 months, we can have a different talk about it. But if you're going to co-sleep, think about it carefully because the risks come if we're not familiar with babies. There are some hard no's. If you or someone else in your relationship are smoking, it's a no. If there's maturity for that infant, it's a hard no. If you're drinking alcohol or taking any sleep medications, it's a hard no. Any medications can affect your sleep, hard no. What are some of the other ones? If you're sick or unwell, your sleep can be affected. So again, another hard no there. But for the rest of the people, it's something that you can do safely if you look up all the guidelines and find out how to do it safely. And there's some really good people on Instagram that provide a lot of information there. So, yeah.
I don't want to go too much in because we could spend hours on this topic, but I think just if you're going to co-sleep, I think definitely just seek out how to do it safely and look out when not to do it. I think that I think, that's the take-home message, I think, because, I think there's so much misinformation that it's hard to pin down exactly on an individual basis. That really does need... And I also, I think, don't be afraid to bring it up with... I think a lot of people will be hesitant to do this, but bring it up with... It's a tricky thing, bring it up with a doctor. And I say that hesitantly because I think a lot of doctors don't know how to safely co-sleep, and then they'll just say, don't co-sleep, which is the worst thing you can say.
That's not the modern way of doing it. So if your doctor says don't do it, you should seek someone that's really familiar with the current way of understanding things at the moment, because the last thing people need is to be told don't do something. That's not what parents need. They need to be given information, empowered, and then the freedom to make their own choices, from an informed point of view. So yeah, but that's a good summary that you get.
Yeah, no, okay. Wow. So I want to put you a bit on the spot now, and I want 3 top tips, right? Okay. I want 1 for baby feeding, 1 for baby sleeping, and 1 for sort of mum postpartum health. I know it's very general, but yeah, what are Dr. Kavita's 3 top tips? 1 for each of those.
Okay.
If you can. I know it's putting you on the spot, but
no. These are great. Okay.
Something I wanted to all the guests to see what they say.
Yeah. Okay. So it's 11 now for me, so I might get a bit rambly. Okay. So just bear with me. So for baby, yeah, they're not going to be short answers. Do you want quick fire answers? I think you can tell.
They can be whatever they want. Just
okay.
Whatever comes to your mind.
All right. Baby feeding tip. I would say the most important thing is to understand what's normal newborn behavior. And for that, to understand that babies cry for more things than hunger. This is a big problem. People think that every time a baby is crying, that they're hungry. Sometimes they cry because they want to be held. They do not like to be put down. There's a study for that, of course. It's called the calming response, the carry response. Basically, the babies calm when you carry them and walk. So so going back to it, the 3 reasons that babies will cry when you try and put them down, and then you think that they're hungry, and then you think your milk is inadequate, or you want to give a top up. It's because they want to be held close, or they want to cuddle. The second thing is sometimes they want to feed or suck to sleep. They have a suck sleep reflex. So, and definitely with breastfeeding, they get certain hormones which help them sleep, but that is another thing that you could be confusing. And the way to differentiate it, and I put this in my lecture yesterday, if a baby, as soon as they've been crying, you pick them up, they go on the breast, and within 120 seconds, they stop feeding, then that probably means they just wanted to sleep, sucking something. That's physiological. If you pick them up and they settle and they're not rooting, you know how they root around and then drop? If they're not doing that, they're probably not hungry. They may get hungry in a minute or 2, but they were crying for a cuddle and closeness. It's normal. That's a normal physiological thing. So understanding newborn behavior, understanding newborn poop, these seem very simplistic, but they can reassure you when you're panicking. I panicked about weight gain and all of this, sent my friend a picture of her pooping, like those white pearls. So do we have biliary atresia, all of that kind of thing. And she did the same when she had her baby. She's like, is that a white fleck? Yeah.
I was obsessed with poos. Oh my gosh, thinking back on it.
And it's good for people to know that even though we know this stuff, right? Like, my friend, and she knows I tell people this, she's a prominent pediatrician, and she's like, do you reckon this is a white fleck, And this was, years ago, but still it's so important to know that everybody feels this way. So with baby feeding, know what's normal, know how to manage it, and understand all of newborn behavior. That's my top quick tip. Understand newborn behavior. So you get a lot of teaching about birth and how to handle it, but you need to look into the newborn time, because at the worst, your labor is going to last 72 hours. You've got to deal with postpartum. Baby sleeping, hold those babies, cuddle those babies. Okay. They love contact. Don't try, and especially in the first few months, get your space the way you need to, but don't judge yourself and don't be hard on yourself if you need to contact nap. At the same time, you're getting that oxytocin surge. I think you can tell I'm not someone who the brain ever stops, right? But the only times it would stop is when a baby's sleeping on me, because that can't beat that oxytocin, right? Like this brain doesn't work as fast as it's the only time I've been like calm in my kind of life. So with baby sleeping, hold your babies. I know it's not exactly a sleep tip. And the other thing is baby wearing, okay? And getting, I got into trouble on TikTok there because I talked about what is ergonomically good for a baby carrier. And it's about the traps. It's about the weight distribution through the pelvis. And there's scientific studies on all of that, of course. I always have to. It's not that I'm obsessed with evidence. It's because when you're searching something new, I have to be able to back myself. And so I can't take it down. And there's nothing that I talk about that I can't be taken down. Okay, so with baby sleep, those would be things. Get a good carrier. And the wrap ones, they're great idealistically, but most people can't manage. I couldn't manage it. Most people I know couldn't manage it. Get yourself a soft structured carrier for the first until they're 6 kilos, and then move to a structured carrier that has good supports and look at ergonomically. Don't just go for the fancy, cute pattern and the popular brand. And what was, I can't read my writing. Was it postpartum? My mum postpartum tip, yeah. My tip would be find something that you can get away from. So like I said, I watch such rubbish TV. And I thought about this, and my husband was like, what are you watching? Even sometimes he's like, what are you even watching? And it was the only way to calm my brain. So know that if you feel something, this is my mum tip, and it's not exactly a real tip, but if you feel something, don't gaslight yourself. If a mum feels something, it'll be real. If you feel, oh, I'm worried about this, go speak to someone who can reassure you. You're supposed to be the mum. You're not supposed to be the doctor. You're not supposed to know if your baby is sick or not. You're supposed to be like, I'm worried. I'm going to go speak to my doctor. And if you can't get an appointment with them, speak to a different doctor. If you can't get an appointment with the different doctor, take your baby to emergency. I always say I'd rather see a well baby 60 times than a baby that waited too long at home. So there's a rambly tips on.
No. That was especially the last one. I think is important. But look, I think we'll have to get you on again at some point to talk in more depth. We've covered so many things. But I think if I follow you, but if people want to follow you, where can they find you, and what's your kind of tag on socials?
Tag? I don't think I have one. Okay, so I'll develop one. A tag.
It's actually your username. So because you're on your, is it your doctor?
Oh yes, okay. I have my tags. Yeah, I thought you meant like a tag line, like I'm from the Anchorman days.
No,
like
tag, another word for username. Yeah.
All right. So on TikTok, I think I'm the breastfeeding doctor. Yeah. You don't see it come up. Let me just check. Yeah. At the breastfeeding doctor on TikTok.
Uh-huh.
On Instagram, I am at Dr Kavita T. Dr.Kavita.T. And I have a free website with fact sheets but a lot of my patients were like, this is why I started to do Instagram. They're like, oh, I love your fact sheets, but could you do some reels? So yeah, so I have a fact sheets, the most common ones, because it takes a long time to type these up. But I always recommend my patients, and any patient at 32 to 34 weeks, start reading my basic section. It's free. Do what you like with it and read that section. There's like 6 sheets, and then read the breastfeeding problems, and then go and talk to your doctor or a lactation consultant about how to maneuver or manage any problems.
Where can they find them? Fact sheets.
The fact sheets are on my website, which is www.letstalkbreastfeeding.com.
Perfect. Okay, Dr. Kavita, thank you so much.
Thank you so much.